So thank you everyone for jumping on. And thank you, Leslie Eber, for being my co-host today for Journal Club. Today we will have Leslie give a presentation on one article and then I'll follow with a second one. So would you like to share your slides, Leslie? And I will go ahead and let you take the
Yes,
lead.
thank you very much. Welcome, everybody. Thank you for having me on Journey Club. It's always an honor. And today I'm going to review, it's actually a clinical practice review just published in the New England Journal of Medicine. Um, I hope that my slides are working okay, called Secondary Prevention After Ischemic Stroke. And I thought this was such a thoughtful article. We often get folks who have had a stroke, and it's really nice to know what the standard of care is in February and March 2026 on what to do next. Okay, hold on. So, here's some background, which I thought was really interesting. Ischemic stroke is the most often caused by, of course, arterial thromboembolization. Stroke is the leading cause of death, and the third leading cause of death, and the fourth leading cause of healthy life years lost. It's equal from between men and women. And meta-analysis said that the annual risk of recurrent stroke after your first stroke was 4.3%, and your risk of myocardial infarction, 0.9%, and cardiac death, 0.5% yearly. So these are pretty big numbers. Recurrent stroke leads to increased risk, of course, of disability, dementia, cognitive decline, and death. And the risk of stroke recurrence is greatest in the first week after your stroke. Okay. So, top five risk factors for ischemic stroke, and these are a lot of things that we already know, of course, is high blood pressure, high LDL cholesterol, high fasting blood glucose levels, diabetes, ambient particulate matter pollution, and smoking. 90% of ischemic strokes have due to potentially modifiable risk factors, and that's what we're interested in. So this review is very dense, so hold on to your hat because there's a lot in these slides, but we'll share them off after, and I'm just going to try to give you an overview. I really loved this slide. This was one of the reasons why I thought this was a great clinical review by the New England Journal of Medicine. Here are the pathophysiological contributors to stroke. They're all the things that we think of: dyslipidemia, heavy alcohol, obesity, hypertension, smoking, physical inactivity, sleep apnea, which is kind of a new one that we don't always think about, diabetes, and of course, atrial fibrillation. And we have atherosclerotic and inflammation on the left side here, and on the right side, increasing clot risk. So, one of the things that they really feel is the most important thing for us to do when we're thinking about secondary prevention of a stroke is to really understand why the stroke happened. What was the pathophysiology? And there are four main causes of pathophysiology in ischemic stroke: the large artery atherosclerosis, cardioembolism from AFib, valvular disease, LV thrombus, endocarditis, small vessel disease associated with diabetes, and then cryptogenic stroke, including embolic stroke of undetermined sources. And this can be up to 30 to 40% of the strokes that we see. Okay. Oh, goodness, sorry. So this is when it gets a little bit heavy, so hang on to your hat. So I'm going to go through all of the sections of secondary prevention for ischemic strokes and what we can do and offer our patients. Some of them will really speak to our patients, and some of them we are going to have to modify for our patient population. The first one I'm going to talk about is lifestyle modifications. And of course, smoking is a big one, especially after a stroke. But I don't think I really realized that continuing smoking after a stroke will double the risk of a stroke recurrence. That's a pretty big number. We can do a lot of things to help folks if they're interested: nicotine replacement, counseling, bupropion, and other medications. When we're also thinking about lifestyle changes, of course, physical activity for at least 20 minutes at moderate to high intensity. Some of our patients can do that and some of them can't. If you come to the CMDA annual conference, you'll learn about high intensity therapy And that can help us prevent stroke, as we see right here. So, another reason to come to the CMDA annual conference in April. So, doing this twice a week is associated with a 40% lower risk of recurrent stroke. That's a big number, 40%, my goodness. And of course, there's a Mediterranean type diet. Now, there's no data on this, but the American Heart Association, American College of Cardiology talk about a diet that's high in fruits, vegetables, grains, and all the things you see listed here. So this is where it gets a little tricky, of course, antithrombotic therapy. So first, we're going to talk about dual antiplatelet therapy, and should be short. We see a lot of our patients when we go through their medication list that they're still on Plavix plus aspirin, and that's when we have to ask why. So this is very helpful for non-cardioembolic minor ischemic strokes. So this is high-risk TIAs, and some other type of small vessel ischemic strokes. And it can really be helpful quickly after the initial stroke. So, maximum benefit of dual antiplatelet therapy is from the first 10 to 21 days after a stroke. After that, there's a lot of risk for bleeding. So, this is a really targeted population who's had a stroke and for a very targeted amount of time. It's also really important that you know that Griglar instead of Plavix leads to increased fatal bleeding and intracranial hemorrhage. So when we're doing this dual antiplatelet therapy, we really want to use Plavix plus aspirin. After that, monotherapy with aspirin or Plavix is usually continued after the dual antiplatelet therapy. Antiplatelet monotherapy with aspirin is recommended for long-term treatment for people with large vessel intracranial stenosis. So this is really important that not everybody is going to benefit from dual antiplatelet therapy, but a subset segment will benefit. So we really want to be intentional on when we use dual antiplatelet therapy, how long do we use it, and what do we do afterwards. Non-valvular AFib, the answer is a DOAC. It's always a DOAC. 50% less risk of hemorrhagic stroke. We don't use warfarin anymore, and you can start it in less than 4 days after a stroke. I think people had a little bit of apprehension about starting a DOAC so soon after stroke. Maybe I'll cause a hemorrhage, but they've done really nice studies, and you are safe to start that DOAC. Patients with other high-risk cardioembolic sources, such as left ventricular thrombus, or if you have a mechanical valve replacement, then you can use those vitamin K antagonists. Those are the very rare instances when a DOAC is not going to be your answer. Okay, having a challenge with my slides, so hang in there with me. What about hypertension? And this is where it gets confusing. Again, another reason to come to the CMDA annual conference with Dr. Carrie Levy is going to talk about how should we manage hypertension in our patient population. And it's a little confusing. As we all know, the American Heart Association, American Cardiology College have put out new guidelines for managing hypertension. And some of them are a little scary for our patients. This is what we know. For hypertension, recurrent strokes was 27% lower with more intensive treatment. We know that systolic blood pressure less than 130 has a lower rate of stroke and death than those who have 130 to 140 systolic blood pressure. But here's the catch. When I reviewed this data, they really didn't talk about the age ranges or people who had frailty or disability information. So this is for the average person. This may not be for our patients. And so there's a tension here. How intense should our blood pressure management be in an older patient who's in a post-acute and long-term care facility who may have multiple comorbidities and may have frailty? I think that's a question that we're still trying to figure out. But we have to be careful when we look at these studies to see if they included any of our patients. So then let's talk about hyperlipidemia. So medium follow-up, this is again another study that was cited in this New England Journal review. Follow-up of 4.9 years, risk of recurrent stroke up to 16% lower in the statin group rather than the placebo group. Statins are good. For every 1,000 patients with a stroke who were treated with a statin, um, an estimated 40 fewer ischemic major cardiovascular events and 6 more hemorrhagic strokes. So there's a plus and a minus here. Overall, though, statins are beneficial. Um, we also want to make sure that our goal is an LDL less than 70. And if you can't get there with just a statin, now we know that there's really strong data for the PCSK9 inhibitors, and we know that they're out there, they're effective, and they can decrease your risk of stroke. There is somewhat of an increase in diabetes that appears to be dose related with statin therapy. I just want you to know that. And they also have other studies that they reference in this clinical review about treating people who have just hypertriglyceridemia, really hard word to say. And that's useful as well. You can decrease your risk of stroke even if it's just the triglycerides that are elevated. Okay. I'm going to master this PowerPoint at some point. So, what about diabetes? Again, these are not in our specific patients. And so, I'm going to talk about this tension here. Diabetes is associated with a 50% higher risk of recurrent stroke. So, that's not to our benefit. Hemoglobin A1C 7 to 8 is a reasonable goal for those with limited life expectancies or multiple comorbidities. But there's a question there because this recommendation is also at odds with the American Diabetic Association recommendations for 2025 and 2026, who said that we shouldn't really be guided by the hemoglobin A1C for our older patients who are in institutional living, in post-acute and long-term care, have multiple comorbidities, and a limited life expectancy. The ADA recommends that we go with preventing hypoglycemia and symptomatic hyperglycemia. If our patients in this section also have had a stroke, there's that tension. Do we do a little bit tighter control on diabetes for that hemoglobin A1C 7 to 8? Or does that put our patients at increased risk of hypoglycemia? And so this is a question for us. 8 randomized placebo-controlled trials show that GLP-1 receptor agonists lead to 16% lower risk of stroke. So we should keep that in our toolbox as well. There's so many reasons to use the GLP-1s, and we'll see about these final recommendations. I just want to touch, because I know I'm running out of time, about revascularization, often not for our patients, but should be done within 2 weeks after symptom onset. And again, we want to look at what the etiology is for the stroke to determine what revascularization would be appropriate. This is not a decision that we're often making. This is a decision that's already been made once we receive our patients for admission. Okay, so this is kind of a summary slide. American Heart Association and the European Stroke Organization advised target blood pressure less than 130 over 80, but didn't carve out our patient population. So this is a question. In selected patients with non-cardioembolic TIA, dual antiplatelet therapy is incredibly useful and prevents recurrent strokes for this patient population for days 21 to 30. And then you want to go to monotherapy antiplatelet treatment. Patients with AFib, it's always a DOAC. Target LDL less than 70%. Start with that statin. Know that you may have an increased risk of diabetes. And for patients with diabetes, they, excuse me, they talk about a hemoglobin A1C less than 7. That can be incredibly dangerous for our patient population. And so again, we have to look at the individual patient, what's going to work for them, what are their comorbidities and their frailty, how aggressive do we want to be with our diabetic control. And finally, metformin and GLP-1 agonists, SGLT2 inhibitors, these are all medications that prevent recurrent strokes, so we should use them well before we use insulin. Okay. I want to thank you for cruising through this presentation with me. Thank you so much.
Awesome. Thank you, Leslie. I see a lot of parallels in the management, of course, stroke with peripheral artery disease, which we'll talk about next. Yeah, awesome. Any questions or comments for Dr. Eber? So before we move on to the second article, I thought we'd just take a moment to remind people, as long as you're sitting here listening to this presentation, take a moment to register yourself for one of the upcoming conferences. Leslie, do you want to talk about the national conference coming up at the end of March? I'll put the link in the
Sure.
chat box.
Thank you very much. So there's still time to come to Pulp Med Annual Conference in Anaheim, California. It's a pretty easy trip. It's about an hour away, hour and 20 minutes, and you still can sign up. It's, I think, incredibly useful. And if you can't come in person, please consider virtually. This year we have the greatest clinical hits. We're going to do this every year. So if you come, you'll have access to what are the standards of care in 2026 for congestive heart failure, COPD, diabetes, uh, hydration, and dementia, and psychiatric care? You can get it all in one place. So please consider it's going to be warm and beautiful. You get to go to Disneyland. Come join us. Thanks.
I'm looking forward to it, yes. And after we come back from California, the Colorado State Conference, our Colorado chapter, will be on April 24th. It's in Denver, and we are live streaming it this year. So there is no excuse not to come. You can come from anywhere. And one of the presentations I'm especially looking forward to is the afternoon panel presentation. Several of our Colorado members will be on that panel talking about on-call conundrums. And I promise it's not just a session about complaining. We're going to talk about how we get through the problems, and there will be some suggestions for audience and some time for Q&A. So please register and come join us. It'll be a lot of fun and a lot of learning. Oh, and this week, I don't know, Leslie, if you knew, we did get approved to provide CME at the Colorado conference. So we are official
Yay.
providers for that. Yeah. Okay, let me figure out how to share my slides here because I'm going to present our next presentation here. Oops. Okay, doing it. So my article is very kind of a similar topic to Leslie's. I hope you're looking at the slides here. Thank you. This one was also published in the New England Journal of Medicine just last month, Peripheral Artery Disease in the Legs, and it ties directly into the presentation I'm giving at the national conference in March on peripheral artery disease in the legs. So thank you, Leslie, for letting me know about this recent publication. But just to remind you, peripheral artery disease refers to atherosclerotic disease, so atherosclerotic disease of the legs in this case. And this is a disease that affects at least 1 out of 5 people over the age of 80. And when people get peripheral artery disease, it puts them at risk for major adverse cardiac events, also known as MACE or MACE, and also major adverse limb events, MALE, male. And these are the kinds of things that we're trying to reduce when we try to treat and reduce the complications of peripheral artery disease. When people present with peripheral artery disease, they can present with a range of symptoms. And the leg symptoms classically are the claudication, exertional calf pain that resolves within 10 minutes of rest. But people also can have pain in their hips. They can also complain of discomfort or an ache. They could just say that they're walking less, or they could present with no symptoms at all. It can be asymptomatic. So in people who are at risk, we're talking about older people, people who smoke, people with hypertension, hyperlipidemia, diabetes, all the same risk factors that Leslie just talked about for stroke. They can have a risk factor for that. Those can be risks for peripheral artery disease as well, and they can present asymptomatically. But we're going to want to watch on our exam and check if they don't have symptoms, check for peripheral pulses. When you're looking at the feet for edema, also make sure you palpate for the dorsalis pedis and the posterior tibial pulse. Look for decreased hair on the legs. Look for decreased sensation and proprioception. Maybe your patient has hammer toes. These can be signs of decreased circulation in the leg. If they have the classic dependent rubor, meaning that when you put their legs down in the dependent position, it turns red, but then when you lift it up and it's elevated for 20 to 30 seconds and it turns white, that's called dependent rubor. That is a sign of decreased circulation to the legs. The test of choice is the ankle brachial index. That is the mean systolic pressure in the ankle over the mean systolic pressure in the arm. That number, if it's 0.9 or below, that's diagnostic for peripheral artery disease, and that cutoff detects a 50% or worse stenosis of a major leg artery. It has decent sensitivity and better specificity. The pictures on these slides all come from the article that I'm presenting, and so it's another nice feature of this article that has very nice pictures. When we're trying to reduce the symptoms of the leg pains, and we're trying to actually increase people's walking distance. And this article has this nice table that shows some of the relative effects of the various therapeutic options for walking difficulty in peripheral artery disease. You'll see on the left side, two of the medications that have been studied for improving walking distance, like semaglutide, GLP-1 agonist, or cilostazol, phosphodiesterase 3 inhibitor. These medications can improve walking distance up to an average of 40 meters, which is about 130 feet. And for me, that means that if I have a patient whose goal is not to walk at least 130 feet more than they can, these may not be good medicines for them. Think about your nursing home patient who's been on cilostazol for years, and you're wondering, oh, they must have peripheral artery disease. How do I know when I can stop this? Well, if they're at a point in their life where walking an extra 130 feet without leg pain isn't the goal for them, maybe they have other medical diseases that keep them from walking, they don't need to continue taking cilostazol. Exercise helps, and you can see from this little graph here that a independent home-based walking exercise doesn't give quite the same benefits as a structured, supervised treadmill exercise that is designed for the patient by therapist. You're going to get different effects, and the studies prove that. Surgery can also help, and the surgeries show that surgical procedures for the larger, more proximal arteries will give more benefits to walking distance compared to surgeries for more of the distal arteries. Other ways that we try to reduce our major adverse cardiac events, major adverse limb events, are with the interventions you see here. I put at the very top, smoking cessation. Just like Leslie said, this is something we have to offer to our patients. And actually, when you look at the data, compared to everything else on this slide, the relative risk reduction of smoking cessation is actually the best. So if people are smoking, they have peripheral artery disease, do what you can to get them to stop smoking and use the available pharmacotherapy interventions as well as your best counseling interventions. Keeping a blood pressure less than 130/80 is the goal for PAD. We do want to lower the cholesterol, specifically lowering the LDL by at least 50% is what has shown to be effective. In Europe, they're actually saying if you have diabetes, to get that LDL below 50. We do want to reduce the HbA1c. Every 1% increase in HbA1c increases the risks for major adverse cardiac events and limb events, like amputations. There is that tension, just like Dr. Eber just mentioned. How much is too much to reduce? How much can our patients tolerate? And I always like to teach that when we're following guidelines, after every recommendation, every guideline, just put the words as tolerated. We want to follow those guidelines as tolerated. You might also see your patients on combinations of antiplatelets and antithrombotics. They might be on a single antiplatelet, like
Hello.
either, hello, hi, we're here, we can hear you.
Who's calling?
Hi. Oh, you might want to mute if you're not talking to us.
I just did.
Appreciate that. They probably just forgot. Yeah. So different combinations of blood thinners. Single antiplatelets like either aspirin or Plavix. Dual antiplatelets like aspirin plus Plavix or any other antiplatelet. And then antithrombotics, which are the anticoagulations. And one of the newer regimens that has been published about lately is the aspirin plus low dose rivaroxaban. And when you see that, that means aspirin 81 milligrams plus rivaroxaban at 2.5 milligrams POBID. These are in the guidelines that as people have more severe peripheral artery disease, you might consider the combinations of blood thinners. And just like with stroke reduction, that kind of gives me pause. We want to make sure we're picking the right patients so that we're not increasing the adverse effects of those combination pills. Now, the guidelines for peripheral artery disease that were updated in 2024 from the American College of Cardiology outlines some of their thoughts about antiplatelets and antithrombotics, as does this review article that we're talking about today. The two are very consistent, and both of those sources basically say you can consider using aspirin plus low-dose rivaroxaban for people with severe PAD or people who've recently had revascularization for PAD, but watch out for people who have an increased risk of bleeding. And to me, I need a little more direction than that. So in the next 3 slides, I'm going to show you some of the thought process that I have and some of the evidence that I've looked at regarding that issue. So the guidelines say that if someone has asymptomatic peripheral artery disease, you could use a single antiplatelet agent to reduce their risk of adverse outcomes. Data is not that great. You might want to pick and choose. For some people, maybe no medication is the better choice. Symptomatic peripheral artery disease can benefit from taking that single antiplatelet, so either aspirin or Plavix, or you can have someone on aspirin plus low-dose rivaroxaban. And where it's really been studied is people who have had surgery. If someone is within 6 months of surgery for PAD, either single antiplatelet. There are people who can benefit from dual antiplatelets, specifically if they have a drug-eluting stent. The dual antiplatelet is indicated for 2 to 6 months, and after that, you'd go back to just a single antiplatelet. And then the other recommended regimen is aspirin plus low-dose rivaroxaban indefinitely. Or if someone's already on anticoagulation for another indication like atrial fibrillation, you can continue their anticoagulation and add a single antiplatelets. These recommendations come from studies that have been done over the last few years. And this combination of aspirin plus low-dose rivaroxaban specifically comes from a couple of studies that I'm going to review very quickly here, the Voyager and Compass studies. The Voyager study looked at people who had recently been revascularized for PAD, followed them for up to 28 months, and their conclusion was that compared to just aspirin, combining aspirin plus low-dose rivaroxaban can reduce MACE and MALE, your cardiac events, your limb events. Yes, the combination is associated with an increase in major bleeding, but overall they felt that the benefits outweighed the risks. When you really look at the study, though, it says that they excluded people who've had a previous stroke or intracranial hemorrhage, anyone with an intracranial tumor or a vascular abnormality, and people with GI bleeding in the previous 6 months. The Compass study looked at people with peripheral artery disease or coronary artery disease, and their conclusion was the same. If you have peripheral artery disease, this combination of aspirin plus low-dose rivaroxaban decreases cardiovascular events in PAD. And when you look at who they excluded from the study, they had high bleeding risk. That's kind of clinician judgment, isn't it? Recent stroke, previous hemorrhagic or lacunar stroke, severe heart failure, advanced stable kidney disease, anyone who is already on dual antiplatelet therapies or other anticoagulation, and also a final exclusion criteria that says non-cardiovascular conditions deemed by the investigator to be associated with a poor prognosis. This tells me that for me as a clinician, if I feel that my patient has a high bleeding risk, if I feel that my patient has a poor prognosis, they don't
my
have.
college kids take fitness classes, which is kind of hilarious. Paying, well, I didn't pay, but $70,000 a year.
We're getting some background noise. If you don't mind muting, that would be great. So be careful with your patients. If your patient has a poor prognosis or they're at risk for bleeding, you don't have to put them on aspirin plus rivaroxaban. It is very tempting to say vascular surgery said to do this, so we're going to do it. Just think about, does your vascular surgeon know whether your patient has a high bleeding risk? Is your vascular surgery team aware of your patient's prognosis? I think together we can come up with the best solutions. So that's my takeaway for this journal. It is good to use a good review article. It'll help us recognize the signs and symptoms of PAD, the diagnosis, the principles of treatment. We should apply guideline-directed treatments as tolerated, always as tolerated. And when we're reading journal articles, we should question which recommendations apply to our patients who are older, who are more frail, who live in post-acute long-term care settings. And when it comes to working with specialists, we need to make use of their expertise and bring to the table our own knowledge of the patients, their prognosis, their goals of care, their risks for bleeding, and collaborate and coordinate that care with our specialists. Thank you.
Thanks, Singh. That was so great.
If there are any questions, please feel free, but we are done and we appreciate you spending this half hour with us for Journal Club today. Thank you to Leslie.
Thanks, Singh.